Welcome back, everyone. Today we are diving into one of the most high-stakes, adrenaline-pumping topics in orthopedics and emergency medicine, compartment syndrome. It is the literal pressure cooker of the human body. Dr. Sarah, are you ready to get into the weeds of why this is a true do-not-miss diagnosis?
Absolutely, Dr. Khan. From a board perspective, compartment syndrome is a favorite because it bridges anatomy with rapid-fire clinical decision-making. We're specifically looking at how rising pressure within the non-distensible fascia of the forearm can lead to devastating ischemia.
I love that term, non-distensible. Let's break that down for our listeners. Imagine you're wearing a wetsuit that's 3 sizes too small. You're already tight, right? Now, imagine someone starts pumping air into that wetsuit. The suit isn't going to stretch. Instead, it's going to crush everything inside. That's the fascia. It's like a tough, fibrous bag that doesn't like to give.
That's a perfect analogy. Clinically and anatomically, the forearm is divided into 3 main osteofascial compartments: anterior, posterior, and lateral. The anterior compartment is usually the most involved. When fluid, whether it's blood from a fracture or edema from a crush injury, starts filling that space, the pressure exceeds the capillary perfusion pressure. If the blood can't get in to deliver oxygen, the tissue starts to die.
Exactly. And why does this matter clinically? Because once those pressures rise, you are on a ticking clock. We often talk about the 6 Ps of compartment syndrome, but Dr. Sarah, which one is the absolute high-yield red flag that we need to catch before it's too late?
For the boards, the most important P is pain out of proportion to injury. If you have a patient with a relatively simple-looking radius fracture, but they are screaming in agony even after a dose of morphine, your alarm bells should be ringing. Also, look for pain with passive stretch. If you extend the patient's fingers and they hit the roof in pain, that's a positive sign of ischemia in the flexor compartment.
Spot on. I tell my residents the patient is the monitor. If they're telling you it hurts more than it should, believe them. By the time you see the later Ps, like pulselessness or paralysis, the game is almost over. You've likely already hit permanent nerve damage.
And speaking of permanent damage, we have to mention Volkmann's ischemic contracture. This is the classic must-know complication. When the brachial artery is compressed or goes into spasm, often after a supracondylar humerus fracture in children, the forearm muscles undergo necrosis and are replaced by fibrous tissue.
And that leads to that terrifying claw-like hand deformity. It's a tragic outcome because it's often preventable. This is why being the doctor of choice in an emergency department means having a high index of suspicion. You aren't just looking at the bone on the X-ray, you're looking at the soft tissue and the neurovascular status every hour.
That hourly monitoring is crucial because the window of opportunity is incredibly narrow. The textbook golden window for a fasciotomy to prevent irreversible muscle damage is typically about 4 hours. After 4 hours of ischemia, the damage starts to set in. After 8 hours, it's usually permanent.
4 hours is nothing in a busy hospital. That's why we don't wait for the labs. We don't even necessarily wait for a pressure monitor if the clinical signs are clear. If you suspect it, you call your surgical consult immediately. Dr. Sarah, walk us through the why behind the treatment. Why is a fasciotomy the only answer?
It goes back to your wetsuit analogy. You have to cut the suit to save the person. A fasciotomy is a surgical incision through the skin and the deep fascia to release the pressure. By opening that bag, you allow the muscles to swell outward, which immediately restores blood flow to the capillary beds. It's a limb-saving procedure.
And it's not a small, pretty incision either. You're opening that forearm up from the elbow to the wrist to make sure every single compartment is decompressed. If you miss one, the ischemia continues in that specific pocket.
High yield point here for those taking exams. Pay attention to the causes. While fractures are the most common, don't forget about tight casts or even burns, which create an external eschar that acts just like a tight fascial compartment. If the cast is too tight, the first thing you do is bivalve that cast. Cut it right down the middle.
Absolutely. Why does this matter clinically? Because the difference between a patient going home with a functional hand and a patient living with a permanent contracture is the speed of your diagnosis. You are the barrier between them and a lifelong disability.
Let's wrap this up with the big takeaways for the listeners. First, the anatomy. The fascia is non-compliant, creating a closed system. Second, the clinical hallmark, pain out of proportion and pain with passive stretch. Third, the complication, Volkmann's ischemic contracture leading to a permanent claw hand.
And finally, the management, a fasciotomy within that critical 4-hour window. If the pressure is high, the knife must fly. Great session today, Dr. Sarah. Keep those eyes open and those pressures low, everyone.